Welcome to tonight's webinar. This is the link, Arthritis, Diabetes, and Heart Disease. My name is Lorena Dinger, and I'm a retired technical editor, a volunteer book reviewer, and a volunteer with the Arthritis Foundation. And if I seem young to be retired, that's because I was forced into early retirement because of health challenges. I've been living with type 1 diabetes, Hashimoto's thyroiditis, celiac, and rheumatoid arthritis, and osteoarthritis. Now, I follow my doctor's advice. I live a healthy lifestyle, eat a nutrient-dense anti-inflammatory diet, exercise, manage my stress, all of the usual things to be healthy. So I was very shocked when I learned about a year ago that I have coronary artery disease. The doctor who diagnosed me told me that it was likely because of disease processes related to the diabetes and the RA. So tonight's expert is going to help us understand more about this connection between arthritis, diabetes, and heart disease, and we'll learn how we can protect ourselves against these complications. Before we begin, let's go over just a little bit of housekeeping. We've muted all the attendees. You can use the Q&A function at the bottom of the screen to type in any of your questions. After we have tonight's presentation, we will do a question and answer session. After the event, you'll receive a post-event survey, and we hope that you really fill that out honestly. That helps the Arthritis Foundation plan events to better serve you in the future. There will be a replay of tonight's webinar. It'll be available in a few days on our YouTube channel at youtube.com/arthritisfoundation and at arthritis.org/webinars. Now, we've got a quick poll for you. Do you live with any of the following conditions? Select all of them that apply. Do you have high blood pressure or hypertension, prediabetes or high blood sugar, type 1 diabetes, type 2 diabetes, heart disease, or high cholesterol? Go ahead and mark any of those that you're currently living with, and you should be able to see how those responses are coming in. We have just over half of the audience with high cholesterol. We've got quite a few people with high blood pressure, prediabetes or high blood sugar issues, and a smaller number have diabetes, either type 1 or more commonly type 2. And 13% of you have none of the above, which is great, and we hope to keep it that way. All right, now let's get started by introducing tonight's expert. We are fortunate to have Dr. Kim Huffman, who's an MD and PhD. She is a tenured associate professor in the Department of Medicine, Division of Rheumatology at Duke University Medical School. She's an affiliate of the Duke Regeneration Center, a member of the Duke Molecular Physiology Institute, and a co-director of the Human Physiology Shared Resource. She studies the effects of exercise and diet on rheumatoid arthritis and biologic aging. Dr. Huffman's clinical work is with the Duke Orthopedics and Sports Sciences Institute, where she's developed a novel sports rheumatology clinic. This clinic sees non-surgical rheumatologic diseases presenting to orthopedics, as well as athletes with rheumatologic diseases requesting advice on safe physical activity. In these clinics, Dr. Huffman's treatment approach emphasizes rehabilitation and exercise training as a means to rheumatologic, cardiovascular, and general health. Dr. Huffman, welcome, and thank you so much for joining us tonight.
You're very welcome. Okay, so it's great to be with everyone tonight. This is a topic I'm particularly passionate about. And so I'm excited that there are so many of you on the web tonight listening to it. But Our goals tonight are to talk about the links between arthritis, diabetes, and heart disease, how we can diagnose these diseases, the common medications that are used, obviously strategies to help reduce the risk of developing or worsening the conditions, and building an effective healthcare team. And the additional resources are listed here on these websites. And the Arthritis Foundation is very good at promoting the wellness resources that are relevant to this talk, which is fantastic. So, just to start out, why are we talking about this? And I think the poll kind of told the story here. Many, and I think we had almost these exact numbers, many of people, well, we didn't start with diabetes, but many of people with diabetes also have arthritis. But many people with arthritis also have diabetes. And if you have arthritis, those adults have about a 50% increased risk for heart disease. So these are important topics. So the question is, why are they related? This is complicated. I think that cardiovascular disease, comes from a variety of traditional risk factors, which range from elevated cholesterol, high blood pressure, diabetes, and you can sort of say the same thing about diabetes. But one thing that kind of links the two, arthritis and heart disease and diabetes, if you put those together, is this idea of systemic inflammation. So much of our arthritides are associated with elevated amounts of systemic inflammation, in particular things like rheumatoid arthritis, psoriatic arthritis, but even arthritides that aren't considered super inflammatory, like osteoarthritis, are associated with increased inflammation. The autoimmunity that predisposes people to have autoimmune diseases like rheumatoid arthritis. We've not talking a lot about lupus here, but those sorts of things also predisposes people to have autoimmune diseases that include type 1 diabetes. And we'll talk a little bit about more about that in a minute. Some of the medications that we use to treat arthritis can increase risk for diabetes and for cardiovascular disease. The big culprit is steroids, which can increase blood sugar levels as well as blood pressure levels. NSAIDs, which were gained a lot of attention 10, 20 years ago for causing cardiovascular disease. But they certainly raise blood pressure, and there is a range of associated cardiovascular risk associated with those medications. And when I say NSAIDs, I mean things like ibuprofen, Motrin, naproxen, or naproxen, those kind of medications. So the one of the big things that seems to link arthritis and diabetes slash cardiovascular disease is metabolic syndrome. And metabolic syndrome is a cluster of syndromatic elements, or I don't necessarily want to say diseases, but a cluster of conditions, that's better, which include what's not listed here is a slightly larger waist size, so abdominal obesity, high blood pressure, high blood sugar or elevated blood glucose, high cholesterol, and high triglycerides. And the cholesterol is uniquely HDL cholesterol. It's actually low HDL cholesterol for metabolic syndrome, but let's just call it altered cholesterol. So these things are typically triggered by obesity, not a great diet, and my favorite thing to talk about is a sedentary lifestyle, because that's something that we can really make an impact on. So again, no one's perfect, and we understand that a big reason these things are linked is arthritis causes pain. It impacts everyone's ability to move, and that really complicates, an ability to have an active lifestyle. So this isn't a judgmental talk. This is, informative, and hopefully, will help facilitate kind of understanding and sort of ways to move forward. But no one, we're not trying to judge here. So yeah, as I mentioned, if you have arthritis, you're at higher risk of diabetes and cardiovascular disease, but there are multiple things we can do to help reduce those risks. Okay. So in the context of diabetes, there are two types, which are talked about a little bit lower on the slide. Type 1, which is really an autoimmune type, and then type 2, which is traditionally associated with sort of older ages, maybe being overweight, and acquired problems, less often genetic, but often a genetic predisposition, if that makes sense. But the symptoms typically for both include having a need to urinate often, feeling very thirsty, feeling very hungry, especially in the context of type 1 diabetes, being very tired, blurry vision, and bruising, bleeding, as well as yeast infections, and other infections. And so I was mentioning this, so, canonically, or what I learned in med school, which I say canonically is what I mean. I think of type 1 diabetes as something that children are born with as an autoimmune condition, but it actually can happen to anyone at any age. But the bottom line is it's an autoimmune disease that targets insulin slash the pancreas. And insulin is the molecule that tells your body to take glucose out of the bloodstream and put it in the places it needs to go. Type 2 diabetes is typically associated with older ages, is considered a metabolic problem, associated more with that metabolic syndrome that I talked about. And it's typically, it begins with what we call insulin resistance. The problem isn't a lack of insulin that is present in type 1 diabetes. It initially starts with a lack of the ability of the body to respond to insulin. So that's called insulin resistance. Either way, these are the two types of diabetes, and they can both occur at any age. So if you're concerned you have these, and you're interested in getting a diagnosis, or you have family members who are, the ways we diagnose diabetes include a hemoglobin A1C test, which is a measure of essentially sugar molecules that have accumulated on some of the proteins in your blood. And so and they accumulate over a long period of time, so that you don't necessarily need to be fasting for this test. They've accumulated on these proteins, and it's the same today as it is tomorrow, as it is the next day. So the measurement, it doesn't require fasting, and the numbers are greater than 6.5, and typically that needs to be repeated. But there's also this metric of pre-diabetes, where if the proteins that are measured, if between 5.7 and 6.4 have a glycosylation, then that's considered pre-diabetes. Another way, perhaps more common for diagnosis, is random blood sugars or fasting blood sugar tests, where the diagnostic criteria are, as you can see there, more than 200 if it's just a random test, or more than 125 if you're fasting. And back to the idea of prediabetes, this is a fasting blood sugar between 100 and 125, meaning if you're fasting, your blood sugar should be below 100. And if it's not, then your body isn't responding to elevated levels of blood sugar as well as it should. And so that's a sign that something's going on. Another Oh, sorry, go back one slide. Yep, another way that diabetes can get diagnosed, it's a little less frequent. It's typically more in the context of pregnancy, but excuse me, we can perform glucose tolerance tests. These are really if these are really nice tests that look at the physiology of how the body responds to glucose and how insulin is secreted. If you have ever heard of glucola, or anyone who is having diabetes in the context of pregnancy, this is typically how it's diagnosed. And so the medical management, as I alluded to before, type 1 diabetes is really a failure of the insulin secretion system. So you need to have insulin. So you can either do that by getting a pancreas transplant, which is where your insulin comes from, or you can have an insulin pump or insulin injections. For type 2 diabetes, the initial response, or excuse me, the initial problem is that your body isn't responding to insulin. But if that goes on for a really long period of time, the pancreas gets out of whack and no longer makes insulin. So we have a lot of medications that work to do different things to help the body better respond to insulin. But if the pancreas fails and no longer secretes insulin, or if the body's ability to respond to insulin is just really poor, there may be needs for higher levels of insulin in the type 2 diabetes context as well. So for both of these, there is a need for monitoring of glucose levels, because they can go up, they can go down, according to medications. And as you eat, glucose goes up. As you exercise or fast, glucose goes down. It's very important to monitor. And the key thing we want to talk about today, or one of the key things, is that a healthy diet and exercise are helpful for both. And so we'll talk about that a little bit more. So medications for type 2 diabetes, I had alluded to insulin, but before someone with type 2 diabetes requires insulin, primarily the treatment is through medications in the form of pills that help manage the glucose levels. And these can cause some side effects. There are GI issues associated with them. And some of these can cause low blood sugar, which can obviously be dangerous. Go ahead. And one of the first line medications used to treat diabetes is metformin. And typically, if someone comes in with either pre-diabetes or early type 2 diabetes, metformin is prescribed. And also it's recommended that people undergo diet changes, exercise, and if relevant, weight loss. And it's typically very safe. There are also some settings where it's been used to treat cardiovascular disease, polycystic ovarian syndrome, and even NEOA. The really interesting thing is metformin may have some impacts that reduce risk for cancer, dementia, and stroke. So, for the medications that we use to treat arthritis, there are a number of those that can increase your risk for diabetes. The probably biggest culprit is prednisone. It increases your blood sugar, also your risk of infection. Typically, we avoid that in people with diabetes, and if needed in people with diabetes, we usually have people monitor their blood sugar as well as their blood pressure. As I mentioned before, nonsteroidal anti-inflammatory agents can increase risk of cardiovascular disease. This is somewhat controversial, but in people at risk, we certainly want to pay attention and talk to people about it. The medications that we typically use for our prototypical inflammatory arthritides like rheumatoid arthritis, psoriatic arthritis, but not osteoarthritis. We treat those with disease-modifying anti-rheumatic agents. And these medications and these are things like methotrexate or biologics like Enbrel. These, because of how they work, dampening the immune response can increase the risk of infection, which can amplify the risk of infection that comes with diabetes. As far as diabetes medications, sulfonylureas, what we call TZDs, and meglinotides are also common to interact with other drugs. So those are things you want to pay attention to. So I'm imagining a lot of people have heard about Ozempic and Wegovy. These are the medications that have hit the TV, internet metrics here in the last year or so, that are being used typically for weight loss, but they were initially developed for diabetes and cardiovascular disease. But what they are is they mimic a molecule called glucose-like peptide, or excuse me, glucagon-like peptide 1, which is a hormone that is in the GI system. The hormone raises your insulin, reduces your blood pressure, but the bottom line is when you have these medications that mimic the hormone, they can suppress your appetite, make you feel full. As a side effect, they can obviously cause nausea, vomiting, diarrhea, abdominal pain, and that typically gets better in side effects like pancreatitis and kidney damage. The really interesting thing is these at higher doses, they seem to work fairly well for helping with diabetes and improving cardiovascular disease. At higher doses, they do help with weight loss. The question is, well, number one, they're super expensive. And number two, what happens when they get stopped? And we can talk about that later in the chat if you want, but this is a critical thing to think about if you want to consider one of these medications. Okay, so I've talked a little bit about heart disease, but let's focus on that just for a minute. So in general, cardiovascular disease or heart disease means things that affect the heart or blood vessels. Usually we talk about the heart, we talk about coronary artery disease, which means clots within the blood vessels that surround the heart and feed the heart with blood so that it can pump and act appropriately. It's the leading cause of death in the US, in women. Actually, I'm not sure that I didn't know that it wasn't in men. It also is the leading cause of death in people with rheumatoid arthritis. This is a big problem that we haven't tackled very well so far. A critical risk factor for cardiovascular disease is diabetes, where people are 2 to 4 times more likely to have cardiovascular disease. So to address what symptoms may be present, if you don't know that you have heart disease, there may be things like feeling dizzy, lightheaded, fainting, fatigue. More common are things like feeling short of breath during an activity or at rest, especially if you're lying on your back at night. Um, rapid pounding, fluttering heartbeat, swelling in your lower extremities, especially. And another big one is if you feel chest pain or tightness, especially if it's associated with pain going down your left arm or in the neck, in the jaw, throat, upper belly, or back. And any pain, numbness, weakness, coldness in the legs or arms can also be associated with cardiovascular disease. And in particular, in women, the typically stereotypical sign of chest pain and left arm pain in the context of exercise is not commonly as commonly seen as it is in men, which is what the silent condition sort of refers to. So women, especially at risk for cardiovascular disease, should pay attention. Sometimes it can present as abdominal pain, shoulder pain, other signs or symptoms. So it's worth having unusual pain addressed, especially if it's in the context of exertion. And in terms of diagnoses, it's important to have, especially for people with arthritis, your rheumatologist should sort of keep track of your risk factors for cardiovascular disease, and communicate with your primary care doctor about things like family history, smoking, poor diet, drinking, sedentary lifestyle. And typically, where I am, the primary care doctor orders the lab work to evaluate for this, which generally includes a fasting lipid panel, which will assess your triglycerides and your cholesterol. And then depending on where you are in the stages of symptoms, it may be important to have an exercise stress test. Certainly EKGs are commonly ordered. And in terms of things that are common to have in the context of heart disease, again, it's really common if there's a presence of diabetes or obesity. And in the context of obesity, we're now recognizing more and more that body mass index, or BMI, isn't a great measure of body fat. Some bodybuilders in particular have elevated BMIs, but have a lot of muscle. And then some very thin people can, or very low BMI folks can have a low BMI, but can have excess adiposity, which isn't ideally helpful. So for medical management of cardiovascular disease, it does depend on what kind they have. Typically, if someone has coronary artery disease, or prior to at risk for coronary disease, they can use these medications. But if they come in with a diagnosis of coronary disease, typically people are started on what are called statins, which are HMG-CoA reductase inhibitors, things like lovastatin. I can go on and on, but these can lower your bad cholesterol. Additionally, people are regularly put on aspirin, which can help prevent blood clots. And depending on the context of how they present, blood thinners like clopidogrel or warfarin, which are Plavix and Coumadin. Beta blockers, which is a blood pressure medication, is very good at reducing risk of secondary cardiovascular complications, as well as ACE inhibitors, which are another blood pressure medication. So for our arthritis medications, considerations for their interactions with cardiovascular disease, and I've mentioned this a couple of times, are nonsteroidals, especially the COX-2 inhibitors, which include Celebrex, it can certainly increase blood pressure. And so if you use those, those should be, blood pressure should be regularly monitored. Newer medications like tocilizumab or Actemra also have these these reports that cholesterol can be increased. But this is a complex, and this is typically a medication used for rheumatoid arthritis. It's a very complicated issue here where people with rheumatoid arthritis often have very low levels of the good cholesterol, HDL, and low levels of the bad cholesterol, LDL. And Actemra can raise these for various reasons. It's unclear that actually the increase in the bad LDL cholesterol causes an increased risk for cardiovascular disease, but certainly something you want to think about. Again, prednisone, never ideal on a long-term basis. It has, bad implications for blood pressure, cholesterol, diabetes. And tofacitinib or Xeljanz is the big issue with this medication is the risk of blood clots, which can contribute to heart attacks or strokes. So these are all, if you've had a risk of blood clots or strong family history of blood clots, then that's certainly something you'd probably like to avoid. And my favorite topic is how can we address cardiovascular disease, diabetes in the context of arthritis with non-pharmacologic strategies. So if so we can do a lot with things like physical activity, healthy diet, and weight management. The other thing is managing the actual inflammatory disease because of the inflammatory link to cardiovascular disease and probably diabetes. So you can potentially reduce the risk of cardiovascular disease with this four-pronged approach that's demonstrated here. So in terms of managing weight, one strategy is to address a diet change that would be anti-inflammatory. And typically high fat foods are considered pro-inflammatory, and these are considered to potentially worsen arthritis or arthritis risk. These also can contribute to higher body fat and blood sugar, and then high blood pressure. Again, BMI is not the best measure, but a real key feature of a risk from abnormal or excess weight is the apple phenotype, which basically, so this is the person with perhaps, say, skinny legs, but a big belly. But it's essentially that phenotype means that there is a deposition of fat, not just around muscles, which would be if they were fat all over, but a deposition of fat around the organs inside the trunk. And so that's called visceral adiposity, which really is a bad harbinger of health. And as far as losing weight goes, across all kinds of arthritis, and I'll say especially osteoarthritis, losing a very small amount of weight can help with pain related to arthritis. And probably reduce the risk of developing arthritis and inflammatory arthritis and gout. Certainly reduces the pain, and you can see losing 5% of your weight can help you cut your pain by 10%. And from a cardiovascular or metabolic perspective, losing weight helps you lower blood pressure, cholesterol, and reduce the risk of consequential diabetes and cardiovascular disease. So the diabetes prevention program was a study of 3,200 people with pre-diabetes, if you remember my talking about that, and obesity. And they lost about 7% of their body weight, and they reduced their risk of developing type 2 diabetes by almost 60%. And you can see every approximately 2 pounds reduces the risk by 16%. So it's not a huge amount of weight loss that's important. It's, and a lot of it is reducing the weight gain that our typical American lifestyle, we gain a couple pounds a year. And so if you can reduce that weight gain and cut the weight by just a hair, you'll have a substantial reduction in risk of prediabetes, obesity, and very likely the arthritis problems that we're talking about here today. We talked a little bit about anti-inflammatory diets. To go into that a little bit more, the DASH diet for heart disease is a strong place to look, as well as the idea of Mediterranean diets. But the gist is fairly common sense, but if not, the key things are, if you're going to eat fat, healthy fats. So one I like to talk about are avocados. They have a lot of fat, but that's healthy fat. Plant heavy is a good idea, and reducing sugar and sodium, increasing whole grains and complex carbs. And another key idea is just reducing ideas of processed foods. If it comes in a plastic bag, think twice. How can you get that out of a plastic bag and into something that comes, right from the shelf? And you can change your diet and get a much healthier diet, which can have substantial improvements. But to actually lose weight, you probably have to reduce your intake of calories, or almost certainly have to reduce your intake of calories. If you follow the anti-inflammatory diets, typically that happens by itself, but sometimes, some additional methods need to be introduced. We talking about healthy fats. So, so good that they have avocados on the list here, and these also include things like fatty fish, olive oil, nuts, flax, and these things help with your cholesterol metabolism pathways so that you can reduce your bad cholesterol and help you attain better what we call glucose homeostasis, keep your blood glucose levels stable. So ideally, if you can limit things that have saturated and trans fats, like red meat, poultry with its skin, high-fat dairy, margarine, processed foods, fried foods, pastries, that's a good idea. In terms of plant-heavy foods, these come inherently with lower fat and help reduce the insulin resistance and cardiovascular disease risks. The higher fiber levels associated with plants also helps control glucose homeostasis, or the blood sugar. And typically, it's very common that most of us are not eating enough fiber. So that you can see what's recommended for men and women below there. Reducing sugar and sodium is important to help with blood pressure as well as inflammation. And sodium is a big problem in our processed and fast foods. Ideally, you'd like to limit that to somewhere between 2,500, 1,300 milligrams a day. The sugar from plant-based foods is probably okay. A lot of my patients ask about sugar and fat from plant-based foods. And again, I think if you use your common sense, if you're eating a non-processed something that's grown in the ground, you're likely to be okay. On the other hand, things that come in bottles like soda and juice may not be ideal. They often have added sugar to them, or are concentrated so that they have more sugar than they should, so that they taste good. And you're much better off eating the actual thing that you can see in the bowl there that's grew on the plant, than you are in drinking it out of a bottle. And in terms of carbohydrates, they're both complex and simple. And carbohydrates are what basically generate glucose, which you need for your brain to develop energy for movement. The more complicated or complex they are, sort of meaning the larger they are, the better. And those are things like whole grains, whole wheat, the rice, things that are less complex are basically simple glucose or fructose. They're very simple sugar molecules that are in fruit juice, in bread, and other sugary substances. And these, because they're so simple, they lead your body to allow itself to raise the blood sugar really quickly. And this, through the metabolic pathways, also contributes to increasing triglycerides. And so carb counting has been a part of diabetes treatment for a while, and it involves counting the number of carbs in a meal and matching it to an insulin dose. This isn't something that I typically talk to my patients about because I don't have a ton with type 1 diabetes. But if people take insulin or type 1 diabetes, then this is helpful, and you can work with a diabetes nutritionist for this kind of thing. And my favorite topic is physical activity. And I want to say that I think everyone with arthritis should exercise. And I say, why? Well, it can improve your health. It can improve your physical health and improve your mental health. So physical activity, because it works skeletal muscle, which is the main organ that takes up glucose by using insulin, physical activity or exercise can improve insulin sensitivity. It reduces the glucose up to 24 hours after a workout. It also, because of the heart that's required to help pump blood to the muscles that move, can help strengthen the heart muscles. The metabolic changes reduce cholesterol and blood pressure. Also, some of the impacts on the hormonal pathways like cortisol, endorphins, and even inflammatory molecules can all reduce inflammation and pain. And so what's the amount of exercise is important. So I understand if you have arthritis, a lot of times it hurts to move. It may be a better way to think of exercise, not necessarily as exercise as much as being physically active, but anything you can do or anyone can do to reduce the amount of time that they are sitting is beneficial. So anything, taking the stairs rather than the elevator, if you go to the grocery store rather than parking in the, first spot, park further away, walking to the mailbox and back, going shopping versus getting delivery is very helpful. Even 5 minutes of movement an hour can help improve heart health, and 5 minutes of walking is helpful. And one idea is that after eating, 30 minutes after eating, 5 minutes of walking is a really good idea, and it can reduce blood sugar. And especially for people who have a lot of pain, arthritis, and or are, pretty inactive, you don't have to start with a plan to run a marathon. The idea is to start slow. Anything is helpful. I tend to tell people to start with what they can do. And a lot of times I ask people if they can walk to their mailbox. Well, if the mailbox is right outside the front door, that's not helpful, but walk, a half of a block. And if that's something doable, then I say, I'd like for you to do that every single day, and then increase that by about 10% per week. Work that up very slowly to 30 minutes a day, 150 minutes a week. One of the things that there aren't a ton of data to support, but it's what we typically say. If after you exercise, you have pain that lasts more than 2 hours, not soreness like, oh, my muscles, I feel like I worked hard yesterday, but pain in your joints or pain somewhere else that lasts more than 2 hours after you exercise, probably you did too much and you want to scale back. And as I mentioned before, the Arthritis Foundation has, as well as their Champions of Yes, which is a great mantra. They have a lot of good resources at the arthritis.org website. And just to talk about some of these, these include the Walking with Ease program, and this can reduce pain, increase balance and strength. Other ways of exercising include cycling, and this may be daunting to some people, especially with arthritis. If you have knee or foot issues, working with a physical therapist, occupational therapist, can help you with appropriate footwear or positioning. If you've never cycled, I would suggest starting with a stationary cycle where you don't have to worry about falling. But eventually, it's pretty safe to cycle around the neighborhood once you get comfortable with it, and can really be a nice activity for people with arthritis. There are a number of programs of yoga for people with arthritis and modifications. Almost all yoga classes offer modifications for people with arthritis, especially wrist problems or knee problems. And yoga has a number of benefits, including reducing stress, increasing sleep, and those sorts of things, and even reducing blood pressure, associated health outcomes. Similarly, Tai Chi, which is a movement-based program, can have a number of health benefits, and their data showing that it can reduce some nerve problems associated with diabetes. I'm a big proponent of both water-based exercise as well as weight training. A little, but they're a little different. One takes the weight off of your joint, so it's really good for helping people who have pain in joints move, because as you're in water, it makes you more buoyant, essentially as if you weigh 50% less than what you weigh if you're on your joints, and even less if you're swimming. On the other hand, weight training puts weight on not necessarily the joints, but on the muscles, which are really important for offloading joints when you use them. So if you can strengthen the joints around strengthen the muscles around a joint that's involved in arthritis, that's really helpful. And it also has important health benefits for blood sugar and blood pressure. And so we are going to talk about ideal ways of building a team that can help with coordinating arthritis, diabetes, and heart disease. So obviously, these include people with advanced degrees like rheumatology, orthopedists, orthopedic surgeons, physical therapists, occupational therapists. For people who have diabetes, typically an endocrinologist is involved, or primary care physician with good training in diabetes management. Advanced diabetes it really needs to have attention paid to kind of health from a podiatrist. And I don't think listed here, maybe it's over to the right, but diabetes care and education specialist to help, especially with sort of nutrition and kind of logistical managements of medications and blood glucose. Heart disease is typically managed by a cardiologist or an expert primary care doctor with those medications. And then again, from an overall health standpoint, in addition to those that I've talked about, like a primary care doctor and dietitian, all of our diseases have associated mental health issues, as well as general, the general population has mental health issues. So it's good to include providers that can help with those things, personal trainers, and I'd like to advocate for exercise physiologists that can help with enhancing abilities to exercise at the right amount, and using the right types of equipment are really important. And because in particular diabetes and some of our types of arthritis can impact the eyes, ophthalmologists are also really critical. And so I think I mentioned most of these, but in addition, these are sort of ancillary providers like social workers, nurse navigators can help with some of the logistical issues with financial insurance problems and coordinating the care between teams, social support services, et cetera. It is important as things advance in our society, we all need to get more and more comfortable with use of the electronic medical record and the electronic means of communications with our physicians in between appointments, after appointments, before appointments. So very critical. And then it occasionally we are required to have medical release forms, which will allow physicians to communicate in a lot of larger medical communities, like where I am at Duke. We often can communicate pretty freely without these forms, but if you're in a perhaps more rural setting where you have a local primary care doctor and then go 3 cities over to see a rheumatologist, you may need to do medical release forms that can allow them to communicate. And so, what do you do when you go in to talk to the doctor? Well, first of all, I would say, doctors are service professionals, in addition to their expertise. So, we're here to help you. So you might as well be completely honest, and tell them, if you're drinking, a bottle of liquor a day, as a recent patient had been doing, you might as well, fess up to that. And that helps the physician figure out, what they need to do to treat you. Um, And, I think it's reasonable to, ask questions as often as you need in terms of being assertive. And, that again, there isn't really a stupid question. And, if you have a doctor who doesn't enjoy answering your questions, then, you may consider looking for somebody else. So I think I'm going to hand it back over to Lorena, right?
Yes, thank you so much, Dr. Huffman. We're going to answer some of those questions from the audience now. I
Okay.
just want everyone to keep in mind, we received a lot of questions both before and during the presentation. We'll get to as many as we can. If we don't have a chance to answer your question, we will give you some resources for further information at the end of the session. All right, so first of all, can you define adiposity for us and explain a little bit more about why that visceral adiposity is such a concern?
Thank you. And excuse me while I just take a break to take a
Okay.
sip of something. But yeah, sure. So our body is made up of primarily water, fat, muscle. Those are the key components. And so the amount of fat you have in your body is what I call adiposity. It's, it can range from superstar athletes who are 10% or less to really obese people who are in the much higher percentages. Um, so adiposity essentially just means how much fat tissue your body has. And the importance is really how much it is relevant to how much muscle you have. So sort of percent fat or percent adiposity and percent muscle. So you want to have more muscle than fat, ideally, or you like to have it as balanced as you can. Fat, interestingly, can be under the skin, which is what we call subcutaneous fat. So you can imagine as we get older, our faces get very thin. That thinness is from a loss of the subcutaneous fat tissue in our face. So the thinness of the faces. So that subcutaneous adiposity, bigger, smaller face subcutaneous fat doesn't have a lot of health outcomes or health implications. Belly fat, on the other hand, you have subcutaneous fat, but also the fat beneath the layers. So you have your skin, then you have fat, and then after that is where you have organs. So the visceral fat is the fat that coats the organs in your abdominal system or abdomen, your heart, your lungs, liver. That's the visceral adiposity. I don't know if I did a great job of answering that. Maybe you can ask for more clarification.
I think that helps. Just
Okay,
the fact that under the skin is okay, but around the organs is a problem.
got it. Yes, exactly.
Okay, great. We have a lot of questions coming in about medications. Can you talk a little bit more about statins, why they're used, what the benefits and risks are, what patients should maybe ask about them?
Yeah, so statins are great medications that can primarily reduce the levels of the bad cholesterol, LDL. In some ways, reduce triglycerides and increase the good cholesterol. So they are often used for people who have elevated levels of high cholesterol, or people who have had a cardiovascular event and their levels of cholesterol may not be, or LDL may not be considered high, but may be considered at increasing their risk for cardiovascular disease. So these are really good medications, and they're very effective in reducing the bad cholesterol. They have some issues. The one that bothers me the most is they can cause some muscle problems, generally, just kind of muscle pain, muscle aching, and some people just don't tolerate them for that reason. But in general, if you have high cholesterol, high LDL, or have had a cardiovascular event, a statin is a really good idea if you can tolerate it.
Do you have any thoughts on using statins as a preventative in people who maybe have RA or another inflammatory arthritis?
Yeah, that's a good question. So I tend to think people with rheumatoid arthritis should be treated similar to people with diabetes, where the threshold, and so the guidelines for treating um, lipids, LDL, other lipid issues have been really confusing lately. So there aren't exact numbers I can throw out, but the thresholds for starting a statin are much lower for someone with diabetes than someone without diabetes. So let's say I'm going to throw out a number. Typically, an LDL of 160 is considered bad, and that's when you would start a statin. If someone with diabetes has an LDL of 130, you would certainly want to start a statin. If someone with cardiovascular disease has an LDL of 100, they should have already been on a statin. I tend to think of rheumatoid arthritis as a diabetes risk equivalent, and so would start the statin at 130. Now, my numbers may be a little off there. It may be that I should use 100, but the bottom line is I think that we should, in the case of rheumatoid arthritis, we should consider using statins if there is an elevation approaching the risk that we would consider for starting one with diabetes.
All right. We're also getting a lot of questions about those GLP-1 medications. Who would you consider a good candidate for that?
So I'm not sure, to be quite honest. These are really interesting medications. I think and this is, I want to say a little, to be honest, a little out of my area of expertise. I think in the context of diabetes, cardiovascular disease, this is a little different story, and the endocrinologist, cardiologist can talk about those. But simply in the context of being overweight or obese, these medications are really interesting. And there are a lot of people who seem to be trying them even when they're not overweight, sort of to like improve their aesthetic, their appearance. So, it's a really complicated issue. So I think diabetes, cardiovascular disease, yeah, consider it, but they're super expensive. I think they're getting covered these days by insurance, but if it for obesity, it's a lot trickier. And to pay for it, it's really, it's similar to the cost for rheumatoid arthritis medications. And if your insurance doesn't cover it, you may be able to do it for a month or two. When the issue that I have with it for weight loss is that if you lose weight, you lose 2/3 fat, 1/3 muscle, ballpark. When you inevitably stop it and gain weight back, you gain a lot more fat than you gain muscle. So you don't gain back 2/3 fat, 1/3 muscle. You gain back mostly fat. So the concern I have is that people may be going through a cycle of weight loss where at the end of the day, they're going to end up with a lot more adiposity, regardless of their weight, or a lot more percent body fat.
Right. Great. Thank you. We've talked quite a bit about coronary artery disease. Can you speak to any relationship between arthritis and AFib or heart failure?
Yeah, so these are great questions. I frankly cannot think of a link, but I would not be surprised if I'm just missing it between rheumatoid arthritis and atrial fibrillation. There are a lot of risks for atrial fibrillation. Even super athletic people Alcohol use, both of those things are risk for atrial fibrillation. So there are lots of risks. So I wouldn't be surprised if rheumatoid arthritis is on the list. But rheumatoid arthritis does seem to, even without the coronary artery disease, to have an impact on the heart where it can promote heart failure. Let me see if I can say this the right way, which is a little different from the kind of heart failure that you typically see where you have a lot of swelling. It's called preserved ejection fraction heart failure, or PEF. So heart failure with preserved ejection fraction. And it's a little different, but yes, and it's probably related to the propensity for rheumatoid arthritis to increase blood pressure, but I'm not sure. But yep, there definitely is a risk there.
Okay. And if the arthritis is in remission or is very well managed, do we still have an increased risk of heart problems?
So this is an opinion question, right? So I think so. So here's my take. I think that the risk of cardiovascular disease, and I'm going to just call out rheumatoid arthritis. The risk of cardiovascular disease associated with rheumatoid arthritis is kind of twofold, is probably too simple, but I'm going to say that. You get the traditional risk factors that come along and kind of associate with rheumatoid arthritis, like being sedentary, being overweight, smoking, the risk factor for rheumatoid arthritis. You also have the inflammatory disease process. Both of these contribute to cardiovascular disease. You dampen down the rheumatoid arthritis inflammation, you I don't know which hand I had. I thought it was this one. You dampen down the rheumatoid arthritis inflammation, you still have these unless you've managed those, right? You quit smoking, you started exercising, you lost weight, all that. So I think it's a combination of the two. It's not, I don't think simply managing disease is gonna reduce the risk of cardiovascular disease in everybody. I mean, maybe there are a lot of people with rheumatoid arthritis who have no traditional risk factors. They don't smoke, they're not obese, they're very active, and but that's not always the norm. But those people managing their disease may reduce their risk. But if you have these traditional risk factors, they need to be attended to.
Yeah, that makes sense to me. That was basically what I was told, is even though my conditions are well managed, there's still a risk there.
Yeah,
So we want to do everything we can to reduce what we can.
exactly.
Can you talk a little bit about artificial sweeteners? Are those a good substitute, or is that something we should avoid?
That is definitely out of my area of expertise. I will say I tend to not use them, but if the choice is to drink a Coke versus a Diet Coke, I choose the Diet Coke. But if it's black coffee versus black coffee with stevia, is probably the wrong word, sweet and low, I really don't know. Again, we're getting into processed things, and I think if you could avoid them, that's great. But if it's in lieu of high sugary substances, it's probably a little bit of a trade-off.
I like to think of it sometimes as a bridge. If you're getting a lot of sugar, maybe you switch out a little bit of that with artificial, and the goal is to wean yourself off of it.
Right.
Yeah. Okay. Is there a link that you're aware of between long COVID and risk of heart disease?
And risk of heart disease. Now, I did not anticipate that question, and maybe I should have, but um, I actually don't know the answer to that question, and I probably should. I'm just going to say I don't know, if that's okay.
Yeah,
I apologize.
absolutely. Like I said, we will have further resources at the end here.
Okay.
So that is absolutely fine. Are there any supplements or herbs that you'd recommend for reducing the chance of developing heart disease or diabetes?
Yeah, so I had a patient yesterday asking, and I think these are great. I would rather and going back to our, kind of seesaw conversation a couple minutes ago, I would rather have the arthritis completely managed with medications if that's possible. But once that happens, I do think supplements, fish oil, is super helpful, in terms of reducing cardiovascular disease, in terms of general health, making sure bone health is good with vitamin D and calcium. Um, I don't necessarily ascribe to a lot of the other supplement recommendations, but I'm not going to say they're bad ideas. That's not really my area of focus. I think some can be helpful. I think the most obvious is the fish oil supplements.
So if someone was going to prioritize just one thing to focus on to improve their health and risk, I think I know what your answer is here, but give us that top piece of advice.
Well, I'd say exercise. So let me say, in the context of something where we have great for arthritis, if we have great medications, I actually think medications are the first thing. I would rather have your disease completely under control with my medications so that you feel great and you can get out and exercise, eat right, have energy. So I do put, but then we have, problems like osteoarthritis where our main medications are pain management. So, and I think it's important to manage pain, but in the context of osteoarthritis where we don't have great medications to manage the disease, I'd put physical activity and weight loss at the top. Now, if people don't need to lose weight, it's physical activity and muscle strengthening.
Right. Well, thank you so much, Dr. Huffman. We really appreciate you lending your time and expertise tonight. And we want to go over just a few last reminders and information for future reference here. We do have a new webinar every month. You can sign up for those webinars at arthritis.org/webinars. Our next one is on inflammatory arthritis challenges and solutions, and that's on November 21st. Next slide. We have connect groups. If you want to talk with other people who know what it's like to live with arthritis, these connect groups are a great place to get support and education and empowerment. We have connect groups on a variety of topics and connect groups by location. You can find all of these connect groups at connectgroups.arthritis.org. And just some of the upcoming events as an example, there's one on gout on November 9th, one for young adults coming up on November 14th, and our LGBTQIA group has a mindful yoga session on November 17th. Thank you so much for attending tonight. We hope you found this helpful. As a reminder, please take the survey that we'll be sending out, and you can look for the webinar replays at arthritis.org/webinars. Thank you so much. Good night.